session. So once again, welcome to our session this evening. We are joined tonight by Dr. Sukaina, who is a palliative care physician with Fraser Health, and she's joined as well by her colleague Salena, Kainth, who's palliative nurse clinician, also from Fraser Health, and they're going to be going over a lot of great information with all of you on their team over at Fraser. Some of you who may have had some good interactions with them already, and some of you this might be new information. So we will be doing a bit of a slideshow for you. So hopefully you guys can all see my slides. I'm just going to make sure, Dr. Care, if you want to give me a thumbs up if you can see that. Perfect. So just to kick us off, we just like to say that we are recognizing that we are conducting our business today on the unceded and traditional shared territories of the Katsi, Semiahmoo, Kwantlen, Kwiatkliem, and Tsawwassen First Nations. So we're very honored to be able to be conducting our conversations tonight on that land. A couple of small housekeeping items. I'm sure for those of you who've been in these Zoom sessions before, that none of this is new. Feel free to turn your camera on. We love to see your faces, love to feel like we're connecting. I know as a speaker, sometimes it's hard to feel like you're part of that conversation like we would normally in an in-person environment. So if you're comfortable, please feel free to turn your camera on so we can build that sense of community. If you are not speaking, we just ask you to keep yourself muted. That way there isn't any of that feedback that goes on in the background. Those of you who've been in sessions with me before often hear my dog, so I'll be sure to keep myself muted as well so that we're not interrupted by my dog in the background. The chat box will be monitored, so please feel free to ask questions of our speakers, interact, say hi to your colleagues. We really want to make this as interactive and personalized as possible, so please feel free to use the chat box. And for the sessionals, please, you have to stay for the duration of the evening tonight to get your sessional. Joanne will send all of the information out to you tomorrow. It is a quick and easy 1-hour session. If you did not receive your gift voucher for your DoorDash, please just shoot me a quick message and we can look into that for you as well. But other than those small housekeeping items, I am going to turn the conversation over this evening to our guests of honor. And we'll hand it right on over. So Dr. Kainth, Salena, Dr. Kara.
Can you hear me okay?
Yeah.
You're good? Okay. Hi, my name is Sukaina. I'm one of the palliative care physicians. And as we already said, this is Salena. She's one of our palliative nurse clinicians. And basically, what we wanted to do in the next 40 minutes or so is really talk about what services we have in Fraser Health for palliative care patients. And then also, hopefully at the end, gauge everyone's interest in whether or not we should be doing a little bit more teaching or education, or if there are other topics of interest that we can help with the future. So in terms of any disclosures, I don't have any relevant disclosures. I don't think Salena has any relevant disclosures. Next slide. And like I said, we really just want to talk about what we can do for patients in Fraser Health, especially as a resource to all you community-based family doctors and nurse practitioners who want to support your patients at home. And it's really important to remember, like, this is a team-based profession. We work with not only our palliative care team, but our services in the community, really to try to help manage and keep people at home for if they want to be at home, and really support people's goals during their end of life journey. Next slide. We wanted to give you a few of our statistics just to let you know that we're a pretty busy service. On average in Surrey-North Delta, at any given point in time, we have about 1,000 patients on file with us. And we get roughly 700 new referrals in any given year, with a length of stay median of about 45 days. So we really become intensely involved with lots of people for very short periods of time. This past year, we were able to support 140 people at home to die at home, and we got 239 of our patients who died in hospice. And then, of course, some people do die in acute care as well. And we look at, and when people think of palliative care, they often think of, cancer, end stage cancer patients, but we look after patients with ALS, MS, end stage renal dysfunction, end stage CHF, pulmonary fibrosis, COPD. So post stroke patients. So we deal with a wide range of end of life conditions. Next slide.
Okay, so our resources include the Home Health Palliative Program, and that's through Gateway and Newton Primary Care. We have a palliative consult team in SMH, which is made of nurse clinicians and physicians. We have a 10-bed palliative complex care unit at SMH known as N52 and our hospices. Next slide. So the eligibility for a home health program is if a patient has a prognosis of less than 1 year, regardless of goals of care. Usually these patients require some type of service such as symptom management, equipment, home support. They have to be 18 years or older. The referral goes through the home health service line and the numbers there. That can be a self-referral, or majority of our referrals come through oncology, acute care, or a GP or nurse practitioner's office.
And so even though we say that if a patient's prognosis is less than 1 year, there is still, what is the need that's driving our services? So if a patient is, even though we may say their prognosis is less than 1 year, but they're really functional, they're not having any symptoms, there isn't a significant role for us to get involved too early. So just keeping that in mind.
And that includes the role of the home health, home care nurses too.
So after you put in a referral, so next slide, what will happen is the home care nurses initially do a safety assessment of the home, and then they go into a patient's home and they actually admit the patient to care. So they usually do an intake assessment, and then after they've done that intake assessment, they're going to come back to even if the patient has been referred in the hospital or by an oncologist, they are going to try to link up with the patient's primary MRP in the community to try to get some of the paperwork and process started. So even if you're not the one who put in that primary referral, the home care nurses are going to link with the patient's MRP. And so typically the first few things that are requested after a patient gets referred are a palliative benefits form, a MOST form, and our palliative care service form. And so I'd like to go through those forms and just kind of give you a few tips and tools on how to actually complete the forms and what they're for. Next slide. So the first form that we're going to talk about is the palliative benefits form. And basically any BC resident who's been diagnosed with a life-limiting illness with a life expectancy of up to 6 months can be registered to palliative care benefits if they wish to receive palliative care at home, and that they consent to the focus of care being primarily palliative rather than treatment aimed at cure. And I can tell you from the completion of a lot of these forms, a lot of people don't necessarily meet that fourth criteria. They're often still trying to go for additional treatments, but we still do often fill out this form anyway. So next slide. So this is the copy of the palliative care benefits form, and it is available online. Like if you Google palliative benefits Plan P, it will come up. But if you need a copy of this form, then we can help make it available for you. And this form gets sent to the ministry in Victoria and usually has a 24-hour turnaround time for it to be approved, but only if it's completed correctly. So we have had a lot of challenges with it just not being filled out properly. So the first part is the patient's demographic information, and then the second part is the patient's consent. However, I mean, most of the time patients are able to sign off on their consent, but if they're not, on the second part, a family doctor can sign as a representative or practitioner for the patient. So if your patient is not in your office at the time, you can actually sign off on this form for them. The next part is the part that the ministry gets really sticky on. You need to actually write in a diagnosis, and you actually need to check that they meet all the criteria for the palliative benefits. And then after that, there is actually a list of, depending on what kind of condition the patient has, there's a list of general indicators and specific indicators that the ministry is looking for to make sure somebody is eligible. So the general indicators are, is your patient having unplanned hospital admissions? Are they having a poor performance status? Are they depending on others for care due to their increasing needs? The patient's caregivers requiring more support? Is the patient losing weight? Does the patient have increasing symptoms despite optimal underlying therapy? Or is the patient even asking for palliative care because they want to stop all other treatment? So those are the general indicators. And so they go from 1A to 1G. And then depending on what diagnosis you put in as a primary diagnosis, then the specific indicators separate between whether somebody has cancer, dementia, neurological diseases, heart disease, respiratory diseases, kidney disease, or liver diseases. So basically, like if you have cancer, like if your diagnosis is lung cancer, you have to either say that they're too frail for further treatment or their functional ability is declining. If they have kidney disease, you actually have to say that they're in stage 4 or 5 kidney disease or decided not to start dialysis. So they're really specific on what actually determines whether somebody's eligible for palliative benefits. And so for a lot of patients, this is really important because this actually allows them to get drug coverage that they may not have already. So a lot of our symptom management medications are covered through this, as well as medications like our over-the-counter laxatives are covered on this. And I think that there's 1 or 2 strengths of Tylenol that are covered. So there are drugs that are available on the palliative benefits formulary that are not available on the other formularies. And then the other thing to keep in mind is your patient has to be actually registered to Fair Pharmacare to be eligible to have palliative benefits. And so one of the things that we've had in Surrey, a lot of patients who come from other countries and they are not BC residents. And so all of a sudden people are sending these palliative care benefits forms to Victoria, but when they're not residents, they're not going to get that service. Next slide. So this palliative benefits also covers some of the equipment and supplies.
Through home health, through the MEP program and advanced equipment like hospital beds, and also covers the cost for their home support. So they don't get charged a per diem for home support.
So it's a pretty robust program. And if a patient has a prescription for medication that's covered and the form is not completed, and the patient picks up the medication, they're not going to get reimbursed after. So for example, if I'm the first person seeing the patient, I will tell the family that wait until the coverage goes through before you fill your medications. Next slide. The second form that I wanted to just talk about is the medical orders for scope of treatment. So this form has been developed in Fraser Health, and it essentially replaces the community DNR form. So we tend not to use a community DNR in Fraser Health anymore, and we tend to go with this, which has been recognized the BC Ambulance Service. So there are 3 sections of this form to be completed. The first section really is, do I want to have resuscitation or do I not want to have resuscitation? So one of those has to be checked. If a patient says that they want to have resuscitation, the second part of the form immediately goes to C2, which is critical care interventions, including intubation. Because if you want to have resuscitation, you automatically would want to have all those other treatments. You can't pick after wanting resuscitation. If you say you do not want to have resuscitation, then it goes down the list of whether you want to focus on comfort care. So that would be a DNR M1, which really means I don't want to have any medical treatment except for those treatments that are aimed at providing me comfort. And then the next level is a DNR M3, which is full medical treatment. So I would want to go to hospital. I would want to get IV fluids, chest x-rays, blood work, all of those treatments to see if it will fix what's happening, short of critical care. And then there's the C1 and the C2, which C1 is, I would want to be admitted to the high acuity unit for BiPAP, for any medications that are not available on the regular floors to help keep me going, with the exception of machines and intubation. And then the C2 is everything, including intubation. So we do have patients who tell me, I do not want you to do resuscitation. However, I would want to go to the intensive care unit up to intubation. But if my heart and lungs just stop, I don't want to have anything done. Now, I didn't mention an M2 because essentially an M2 is a facility specific designation. So when somebody's at home, they can either choose an M1 or M3. When I think of an M2, I think of perhaps a long-term care facility that has access to IV fluids on site or additional enhanced medication. So being able to have certain medical treatments that are aimed at fixing something in your area of in your location. So essentially, if somebody's at home, it's an M1, M3, C1, or C2. It's usually not an M2. I'm just going to stop there and make sure that there are no questions so far. The one other thing, this third section of the MOST does mention specific interventions like blood products or tube feeds or dialysis. And I would say by far and away, most people don't worry about filling that part out. But if you know that information, that's great. So are there any questions so far?
No questions in the chat. Does anybody want to unmute themselves and ask any questions so far?
Hi, it's Navi Garcha. Dr. Sukaina, I just had a question in terms of the MOST. So when we are filling it out in the community setting, it can be super helpful, if that information or these conversations have been had, in the community prior to them, if needed, be admitted into the hospital. Is there somewhere where we can either kind of make this information known once patients have filled it out?
So what happens in the community is we give our patients a green folder to put on their fridge. So they usually have this information in their home, so that if they were to call the paramedics would take the form with them to the hospital. And that if you filled it out on a palliative patient, usually the home care nursing team is going to ask for a copy of it. And if a patient had one of these filled out in hospital, usually, or on what's that?
Or by oncology or a specialist.
Yeah. Usually under the risk legal tab in Meditech, it's usually also there. But it's hard to make sure that all the relevant parties have the information, but we usually make sure that the patient actually keeps a copy of it in their home in a green folder, which has like even magnets on it. So that when I go into a patient's home, I'm usually looking at their fridge to see if they actually have one completed.
Okay, perfect. Thank you.
And just another thing, when Sukaina will go over this in the next slide, but if the form has been filled out by acute care or an oncologist, when home care nursing admits them, they will flag it on one of the information sheets that they send you that it has been completed and what it is. If there's not one done, often the home care nurses start having those conversations and will usually fax you saying we've started the conversations, this is what their kind of goals of care are.
There's a question in the chat. How is pharmacare benefit different for palliative patients?
So the pharmacare benefit covers different drugs than the typical palliative care, like than fair pharmacare. So even if you do not meet eligibility requirements for fair pharmacare, like your income is a little bit higher, then you will usually get coverage for medications like hydromorphone. And then on top of it, the palliative care benefits will also provide you coverage for over-the-counter medications like Senna and lactulose. And beyond that, it's not just for the drugs. It will also help with the home support, as well as the equipment and supplies that are available through the home care nursing program.
Another question, is there a billable fee or a fee code for filling out the palliative care benefit form?
So now because I work on the other end of this, I'm not familiar with all of the fee codes that are available, but my understanding is through the GPSC, there is one palliative care planning fee code that covers $100. So yeah, so I'm pretty sure there's a palliative care fee code. And then if a home care nurse calls you, you can always bill that as a 13005. So those are the two fee codes that I'm aware of. And then the other thing is you can always, now with COVID and all of the televisits, you can always call your patient up and schedule this as a visit to complete some of these forms.
And then just a question, maybe if you could clarify a little bit why family physicians need to fill out the medications, including narcotics, when the patient is under the care of a palliative care physician.
So we will talk about that going through this a little bit more. So next slide. So that question that you asked is probably one of the bigger questions that we get, and we will talk about it. So, and then the other form that we get is the palliative care service form. So basically, the question here is, what is your availability to support a patient at home? Are you able to do home visits? So it'll ask a bunch of questions about your availability. And then at the end, which is the part I really wanted to get to, it has a couple of orders that, so that if a patient is struggling at home with urinary retention or needs to have some managed bowel care, that the home care nurses can start on doing that, as well as pronouncing the death at home. Okay, so next slide. So what does the home health team offer? So we have home care nurses who are available from pretty much 8 in the morning to 9 o'clock at night to support and visit patients as needed. They help with symptom management and planning. They liaise with community family doctors and nurse practitioners in regards to care. And then they're able to give families the after hours support, so that in the evenings they have somebody from 9 p.m. to 8 a.m. through the palliative nurse clinicians who are on call for the service. Home care nurses don't visit necessarily every day. They triage patients based on their needs or symptoms. So sometimes it's a daily check-in, a weekly, bi-weekly, monthly, by phone. So it really depends on what the patient's needs are, how that's triaged. And the home care nurses are the primary link to the palliative consult team, which is what we'll talk about in a little while. And for patients who are on the palliative care program, they have access to home support workers, which are people who they're basically care aides who provide services such as showering assist, bathing assist, but they can't administer medications or make any health decisions. So sometimes we have had home support workers, like if a patient is at home managed by their partner and their partner needs to have a couple of hours to go do their own doctor's appointment, we can have a home support worker come and provide respite for them. Next slide. And so some of the equipments and supplies that can be offered are, for example, a hospital bed, a commode chair, a sidebar to help with lifting out of the bed. But there are certain things that require qualifications. So if a patient has a history of dyspnea, they actually have to prove that they're hypoxic to qualify for home oxygen. So that's not something that's provided by the palliative care program. They have to qualify for home oxygen through the home oxygen program. And then some of the supplies that aren't covered are things like if a patient has a tube feed or has an ostomy, we don't have those types of supplies that are covered with us. And if people want to have like things like supplements like Ensure or Boost, we don't have availability to cover that. So in those situations, we'll look at the patient's third-party insurance to see if they have coverage to make that happen. Next slide. So the home care nurses are the primary people who are out there in the community looking after palliative patients at home. And then beyond that, they actually have access to our palliative care consult service. So that includes a palliative care physician, we have a palliative care nurse practitioner, we have our nurse clinicians, we have social work, we have a pharmacist, and we have a spiritual care practitioner. So basically, we help to support community family doctors and nurse practitioners in the management of the patients in a consultative capacity. So the home care nurses will often reach out to us to see how we can help support keeping somebody at home, or to help with advanced symptom management, or help with planning for hospice or home death planning. Our team has the ability to access our palliative care complex unit, which we will talk about in a little while. Unfortunately, due to our limited coverage, we can't take over care, and we don't have the capacity to be backups for refills. Right now, in all of Surrey and Tsawwassen and Ladner, there's roughly 0.7 physician FTE to cover all of Surrey and Ladner. So we don't have the capacity to take on primary care or primary palliative care for all the patients. We do try our best to support people as much as we can as we hear about them and as we hear their needs. Do you have anything else to add? Next slide. So if you put in a referral to our program, it can take some time for patients to actually be admitted onto the service. And so just to bear in mind, like being proactive, recognizing that people, their conditions are changing so that we can try to get on and get them support earlier is really important. And then the other thing is, realistically, when we look at how much support we're able to offer in the community, it leaves people with 20 out of 24 hours of them managing things by themselves, right? So they have their care aides who come in who are not able to make judgment calls. They have access to home care nurses, but realistically, families are left alone to make a lot of the judgment calls and take care of a lot of the physical care by themselves. So it's not a surprise that a lot of people do wind up in a hospital, but there's no capacity for any additional home support beyond what's offered through this program at this time. Do you want to stop for questions and see if there's anything, or should we wait till the end, April?
There's a few, so I mean, if you're reaching it later on, then just let me know, but I'll start from the beginning. What if the palliative care team is looking after the patient? Can a GP still bill the palliative care fees?
So the palliative care team will not bill that palliative care planning fee. We won't bill it. So if you have a visit with your patient and you go through the MOS and you go through all of that, we don't take over any of the MRP, we don't bill any of those GPSC codes. So whatever you need to do in terms of billing it, our team is not going to impact that.
Perfect. And there is, for those of you who had some questions on what the fee is and what the fee code might be, I think Dr. Neelavar posted it in the chat, so you can go take a look at that. There is a question for the panel. Any suggestions on navigating pathways to find all of these forms?
So we are actually in the process of updating pathways from a palliative care perspective, and hopefully we'll get some more clarity. There is a palliative care tab, and all these forms should be there. And after we're done, I actually am involved in part of that pathways project. So I'll make sure all of these forms are available there too.
And then a last one, and you kind of touched on it about referral time, but is there an approximate referral time? Is this how fast can the patient be seen once we make a referral?
That's based on what the priority from the referring source says it is. So sometimes if it's a palliative patient that is imminent and they've just come home from hospital, sometimes that's 24 hours. And then the nurses will again screen and call the family to see what exactly their needs are, to figure out the priority. So they try to triage as best as the GPs and NPs, and then we just try to get out there as soon as we can.
Great, thanks. That was all for right now. I'll
Okay.
move along the next slide.
Sure. So I just wanted to touch base on a few of the other resources beyond the home care program. And one of the biggest resources that we have available to us in palliative care is our hospice. And so we have many end-of-life comfort care beds in the Lower Mainland. So in Surrey, we have the Laurel Place, which is a 20-bed unit. We have a 10-bed unit in White Rock, and we have a 10-bed unit in Ladner. So if your patient, like for example, if your patient lives in Surrey and their family lives in White Rock and they want to go to the hospice in White Rock, it's a regional bed service. So you can go there. The home care nurses are the ones who make the do all of the admission paperwork for hospice, so we can try to get them to the location that they want. But there aren't any guarantees because it really depends on the availability of beds. When a patient is in the community and they're doing okay, but they want to go to hospice, we try to be proactive and get them on the list sooner rather than later so that they don't have a crisis in the home that prompts them into emerge. And one of the conversations that I often have with patients in their home is to, as soon as things are starting to become a little bit more difficult and you really have a specific hospice that you want to go to, please let us know, because we want to do that more proactively. And I know that the restrictions due to COVID have made it more challenging, but before COVID, you would be able to go out on a pass or stay overnight in your home. And even right now, during the restrictions are such that you can still go out and go home for like a night or an evening from hospice. So if you go there a little bit earlier than you intended, then you can still go home for a little bit. So getting that bed before you really need it is important so that you don't wind up in hospital. Apart from the hospice in Langley, all the other hospices have private rooms. So usually they have their own TV, their own fridge. And so it is a nice environment. There's 24/7 nursing. So the care there is quite excellent in my opinion. Next slide. So in order for someone to qualify to go to hospice, they really have to be in their last 6 months of life, and they have to have a good understanding that they have a life-limiting illness, or that if they don't want to know, so that we have quite a few patients who don't want to know anything about their condition, but as long as they say, I don't want to know, please defer to so-and-so, that's fine too, as long as they want to focus on comfort. So they have to really be an M1. We don't leave people alone to die. People often get afraid that when we go to a hospice, we're not going to get care. No one's going to visit us, everything, we're just going to be left alone. I would say the nurses are super intent on making people as comfortable as possible. We do a lot of therapy there to make sure people are comfortable, a lot of pain management, a lot of nausea management, constipation management, and we really try to give families that space. We do on occasion get challenged because people would like to go back to hospital, but then we have to reinforce before they come to hospice, what we can and can't do. So, when people come to hospice, it really is a time where I don't want to have any more treatment. Don't try to poke me with anything. I don't want to go back to hospital. And that patients and families understand that when they come, it is expected that their condition is going to change. We do from time to time get requests from hospitals where a patient wants to come to our hospice to get stronger before going home. We're not really a rehab unit. We don't have physio on site. So really, if people are looking for functional improvement, the hospice is not the right place for that. Next slide. So, it's hard to prognosticate at the best of times. It's often quite easy when it comes to patients who have cancer, but we do have challenges with trying to figure out whether somebody is prognostically appropriate. And so often the conversation I'm having in a home is if they're having difficulty managing at home and we're kind of not sure prognostically, as long as a patient and family are aware that there is a chance they could be transferred to a long-term care facility from hospice if their condition is stable, because we do have patients that do improve. So just to keep that in mind, that oftentimes people think that when they come to hospice, that's it, they're not moving anywhere else, but we do have times where we do move people to other facilities or even home if that's their preference, if they're doing reasonably well. Next slide. So when we think about patients who come into hospice, if a patient's already in a residential care bed, we rarely take them to hospice unless there is some sort of symptom management need that can't be met in residential care. So we really don't take a lot of patients from long-term care where they're already in a bed to another bed. And also, we do have limitations in what we can offer in hospice. So if we have safety risks with patients who are very, very agitated, we're not able to get them comfortably sedated, we have transferred patients to hospital from time to time. If patients are very firm on wanting high flow oxygen or certain treatments, we can't always manage that. And then the other thing to keep in mind is a transition to hospice is usually in an organized fashion, usually from Mondays to Fridays, unless it's pre-planned. And then the other thing that often makes things difficult right now is the COVID visitor restrictions. I will say that relative to the other facilities, hospices tend to have the loosest visitor restrictions in the system compared to long-term care or to hospitals.
But some of our hospices are in long-term care buildings, which has made it very challenging.
If a patient was struggling at home and let's say they went to the hospice in Surrey, but their preference was the hospice in White Rock, we can try to get them to the hospice in White Rock. But it does take time and it depends on availability. So I try not to promise people that they'll be able to move from one hospice to another, but it can happen. Next slide. We also in Fraser Health have 3 palliative complex care units, and basically the 3 units, one in Burnaby, one in Surrey, one in Abbotsford, they're really meant for aggressive symptom management and complex psychosocial issues. So when we have patients whose symptoms, despite our best of our abilities, we can't get them controlled at home, we will often send them to the palliative care unit to see what kind of symptom management that they can offer, with the purpose of eventually transitioning a patient home or to hospice, hopefully in a more comfortable state. Next slide. So our palliative care complex unit in Surrey is N52. It's a 10-bed unit, and it can accept direct admissions from the community based on, let's say, my assessment or assessment from a home care nurse. It doesn't require the same category of goals of care as a hospice, so they do take more aggressive people who have more aggressive goals of care, as long as they do have a reasonable understanding of their disease. But at the end of the day, it really is a short stay unit to try to help stabilize people, get them home, get them to hospice. I get a lot of requests in the community, but can I go to the palliative care unit? And, we don't have patients, like let's say at an M3 level, go to stay on the palliative care unit for ongoing treatments and end of life care. So at some point, the palliative care unit tries to move people who are no longer requiring their acute services to a hospice, to home, or to another medical unit. Next slide. And so then the other final piece of our services are that we do have a consult service in Surrey Memorial Hospital. They are, they get referrals from all the hospitalists to see what they can do to help with pain and symptom management, planning for hospice, complex discharges. We get a lot of patients who are very close to end of life and have decided they just don't want to die in hospital. So that requires acute interventions from our team to kind of get supports very quickly in their home. And then we do get, that's a large number of the patients we get from on the home care nursing program have actually been referred through the palliative care team in Surrey. Anything you want to add about that? No. And so now we also have our after hours availability. So next slide, sorry. So there is a palliative care physician who is able to contact after hours on evenings and weekends. And usually when we get calls, it's usually from the home care nursing team for urgent issues. It's from our perspective, it's very challenging to provide direction to patients if they haven't been seen by our team and if goals of care are not in line with comfort. So for example, I do a lot of call for the after hours. So if I get a call from a home care nurse, if a patient's goals of care, it's Saturday night, if a patient's goals of care are comfort, their condition is changing, they're no longer able to swallow some of their medications, and they really have been hoping for a death at home, I really try my best to try to support that and try to arrange for medications to be given subcutaneously, and I see what I can do. If goals of care are not really clear, I'm feeling a little bit less comfortable to do that type of support. So it depends, because there is a large group of us who do this call, it really depends on the practitioner, what they feel comfortable with, what they will offer when they get a call from the home care nursing team at home. Next slide. So I just wanted to spend the last few minutes talking about what end of life care at home looks like. So, we have patients, like I said, prognosis is less than 6 months, less than a year, but really it's the last few days or weeks that a patient's condition really changes quite dramatically. So what we try our best to pre-plan this as much as we can, but we don't know when a patient's condition is going to deteriorate. So the home care nurses and us, if we want to have somebody die at home and we think the prognosis is in their last few days or weeks, we try to make sure that we have an expected death at home form completed, and then we try to make sure we have some end of life crisis care meds in the home so that we can manage it if things change really quickly. So next slide. So this is what an expected notification of expected death in the home form looks like. So basically it's completed and is valid for 3 months after completion. And basically what it states is that this patient is anticipated to die, and so that if they do die at home, 911 doesn't need to be called, the coroner service doesn't need to be called, and basically what happens is the patient's family waits for an hour or so after the patient has died and contacts the funeral home to say that they've died, and the funeral home will come and pick up the body. So it allows for things to go more smoothly. But the key is the funeral home has to be in receipt of this form before the patient dies. So there is some pre-planning involved. And then the physician who signs off on this form is responsible for completing the death certificate after the patient dies. And I didn't put in a death certificate in this, but a death certificate, you can actually get copies of them from the vital statistics. They'll send you a bunch, like 50 of them, and each death certificate has its own number at the top, because everybody requires a different coded number for a death certificate. So it's a very specialized form that is individualized for everybody. I think that's what I wanted to say about that. Anything else you wanted to add about
Yeah,
that?
so normally what would happen if the home care nurses are involved in a patient, they'll often have the discussions about a home death, and oftentimes you will get the notification of expected death at home faxed to you. And the nurses or the social work with the family on, or helping plan about the funeral and the funeral home, and often the nurses will fax it to the funeral home and make sure that the family has a copy in their home. When the patient does die, the home care nurses usually will call your office to let you know the date and time for the death certificate, and then the funeral home usually would contact the MRP for that death certificate.
Okay, and then next slide. And so in the past, we used to have a community drug box program, but we had to remove that. And so at this moment in time, what we do provide family doctors is the palliative care dosing suggestions for different and common symptoms that we see, as well as a pre-printed order set for what are the common starting doses for a reasonably non-complex palliative patient. So you can check off what you want, and this piece of paper, this community prescription, acts as a prescription for all of the medications with the exception of the hydromorphone. So you still need to supply a triplicate prescription for the hydromorphone after you do that. And if you have questions or concerns, or you're being asked to do this and you don't know what the dosing is, connect with your home care nurse, and they will connect with our team if they need, so we can provide you with some of that information to help support your patients at end of life. And again, this is for the standard non-complex palliative care patient. If your patient is on higher doses of the medication, they will need to be on higher doses of injectable medications. And again, we can help with those calculations, helping you figure out what you need. We're really only a phone call away. So next slide. So that being said, we do have a consult line, and it's available for all the community palliative patients in Surrey and North Delta. We will get back to you within 1 business day with that line, but most family doctors and nurse practitioners reach out to us via their own home care nurse, and the home care nurses tend to be the primary link to reach us. That really is the end of what we wanted to present today. The only thing I wanted to just kind of briefly touch on is medical assistance in dying, because I tend to get a lot of questions about that. Our program helps to support some of the conversations around medical assistance in dying, but the medical assistance in dying, there's a completely different team that's involved in Fraser Health with medical assistance in dying. So we're not the ones responsible for that. And I just wanted to throw that out there. And I think that's really all we wanted to present today. So we'll open it up to whatever questions that you guys have.
So I'll see some of the ones in the chat, and then if anybody had a question they wanted to unmute for, please go ahead and do that, or raise your hand, or continue to write them in the chat. But to start, when does the home care nurse contact the palliative doctor on call versus the GP?
Usually they will always try to reach the GP first. That's their first line of contact. If they can't reach, or the office is closed, or they're not getting a call back, some GPs and nurse practitioners, if they know their patient is fairly close to end of line, have supplied their cell phone numbers. But that would be their first contact. And if they're stuck and they don't really feel they can't wait till the next day, they would call the palliative physician on call.
All right, thank you. Earlier, sort of midway through your slides, you were going through the different locations for hospice. So one of the questions is, did those hospices only serve Surrey residents? If the patient's from another Fraser Health area, does each city have their own hospice?
So not every city has its own hospice, but in all the hospices in Fraser Health serve all the clients in Fraser Health. So I have had patients from Abbotsford come to Ladner. It really, like, you're not waiting longer if you're within Fraser Health for Fraser Health hospice. If you want to go to the hospices in Vancouver, it's far more limited to try to get into a hospice in Vancouver.
Yeah, Vancouver has less hospices than us in beds, but we do accept Vancouver patients if they're hospice appropriate. We even had someone from the interior or the island. Yeah.
So we tend, so like if you have a patient, if your patient is in Burnaby and they want to be in a hospice in Surrey, we can make that happen. If your patient is Surrey and they want to go to the hospice in, is it Tri-Cities? Is that in Tri-Cities, that can happen too. It really just depends on bed availability and like who comes first. But community patients overall are prioritized over like hospital patients. So if your patient is in community, a bed opens up in the hospice in Burnaby, they will get priority over hospital patients. And it really, in terms of community patients, it depends on when they get put on that list.
Thanks. There's another question about the medications. If a patient is being recommended to have injectable hydromorphone, how do you provide the prescription without knowing the total amount to prescribe around unclear PRN usage?
So I tend to be generous. And you know what will happen is you're going to be asked to do refills. So, you know, usually, like, for example, if hydromorphone is, if you're starting somebody on like a 0.25 milligram dose of hydromorphone and it's PRN, usually it comes supplied as 2 milligram per mil vials. And I usually give 10 mils to start off because that's what a box will carry. And it's usually home care nurses who are drawing up these medications, kind of overseeing their use. And like I had mentioned before, the home care nurses are doing a safety and a risk assessment. Like, we can't prevent diversion 100%, but usually when we're prescribing, we tend to feel fairly comfortable that it's being used for the intended. And if you don't feel comfortable giving a lot, you can actually part fill your hydromorphone prescription and say, give 5 vials every 3 days. But you have, like, different patients will use different amounts of hydromorphone. And so you may be asked more frequently, less frequently for refills.
There's just a couple of quick questions here. I know we're almost at time, but I just want to clarify that we will be sending out a copy of the slides. And for the forms that you showcased on the slides, will we be able to send out copies of those, or are these currently located on Pathways?
So you have copies of the
Yeah.
slides, right? We can send you copies of these, so that along with when you send out these slides, you can have copies of the forms. We'll send that to you later, and then you can hand it out. Ideally, all of these forms should be quite available on Pathways, but
Excellent.
it's hard to find them. So
So I'll just do 2 quick questions. One of them, how many palliative care physicians do we have in Surrey/Fraser Health?
So I can't tell you in Fraser Health, in Surrey. So I'll tell you what my job is. I actually cover the community there are 2 home health offices in Surrey. So I cover one of the 2 home health offices at a 0.3 capacity. And then I'm in Ladner managing that hospice, the consults in that hospital, and the community of Ladner. There is another part-time community palliative care physician who works about a 0.4, 0.5 for the home health office of Newton. So for the community, we both cover Surrey. There is one doctor in White Rock. I cover Ladner. And then there's a few palliative care doctors in Surrey Memorial Hospital. So that's probably 5 or 6.
And then there was
And not full time.
yes, you mentioned that. There was a quick follow-up question about the medications. Is the hydromorphone and other end-of-life medications routinely dispensed weekly? Once a patient passes away, does the pharmacy pick up the remaining hydromorphone?
So the dispensing of hydromorphone depends on what physician writes on the prescription form and how much is dispensed. We usually leave it to families to determine whether they're going to return the rest or not.
So usually, yeah, it's up to the family to return the rest of the medication. Usually nursing will call a week to 2 weeks after to do a bereavement call and just to check in that they were able to return all the medications and the equipment got picked up.
I would say, like, I know most people are worried about the diversion of these medications. I would say that we haven't as a team worried significantly about diversion for the vast majority of our patients who are on the palliative care program.
And I think if it's clear that there's a risk, it's very early on, and we kind of don't even put home as an option. It's usually hospice.
Yeah, we've actually turned people away. We've actually said we can't support you at home if we're worried about misuse. And then we tend to be kind of creative. So in some situations where people really want to be home, we will have medications daily dispensed. So we have worked around creatively. And if you're worried about a patient, you're thinking there's a significant worry for diversion, then connect with us, because our home care nurses are going into their homes, seeing what their living situation is like. And I know that it can never 100% be known for sure, but we do try our best to do safety assessments in regards to that.
Thank you so much, ladies. We are at 8:03. There were a few more questions in the chat, but just to be cognizant of time, I think what I'll do, well, actually leave it up to you guys. Did you want me to go through the remaining questions, or would you prefer that I send them to you? You can answer them and then I can send them out sort of as feedback afterwards.
I think we can answer, like, if other people want to leave and if you want us to answer the questions, we might as well do it, right? It's fine by us.
Okay, sounds good. Should the most form be signed by a legal representative if preferably, sorry, let me try that again. Should the most form preferably be signed by a legal representative if the patient cannot sign the form?
The most form doesn't require a patient's signature, so it needs to be signed by a physician. So there's no spot on the most form for it to actually be signed by a patient. There is a part of the most form that says, who was this discussed with? And if you are not discussing it with the patient yourself, you can write on the most form, this is why we didn't discuss it. Like we deal with a lot of patients who are pretty much, their level of consciousness is like they're sleeping all the time. They're not able to answer. And so we will write on the form saying patient unable to be part of the conversation. So, but yeah, they don't actually need to sign a most form.
And then at what point is the palliative care team doctor involved in care?
So I get involved based on referrals from the home care nursing and the palliative nurse clinician. So I tend to get involved in patients where there's significant complexity, or if something is urgently needed and we're not able to get connected with the family doctor. So there is no specific rhyme or reason why I get involved except based on needs. And so what I do is I go in, I act as a consultant, I make recommendations, I start people on medications, and then I step out, and then I step back in again based on what the need is.
And then I think this is the last one. If you could provide some more guidance or information on when the MRP is expected to prescribe injectables. In some instances, when they request stat prescriptions, it's hard to do this.
So this is a real challenge for all of us, because I also get a lot of requests for stat prescriptions for patients. And the challenge really is that you don't know when your patient is going to deteriorate. I don't know when your patient is going to deteriorate. And it's just kind of keeping in mind that on average, a family doctor is going to have 2 to 3 palliative patients per year, and knowing that these patients are just going to need extra support really quickly. So some of the things that I've done is I have an e-fax service, so that if I'm getting called and it's at the end of my day and I'm not near a fax machine, I will use my phone and e-fax prescriptions in to make sure that they're available. We try as much as we can to be proactive as possible to make sure it's recognized, but we also don't want to put in medications too early and have them sit there, and we don't want to wait too late and the patient is struggling. So it's a fine balance that we are always working with here.
Thank you very much. I think we've gone through all of the chats. I apologize if I may have missed one. Feel free to email me, and I can certainly reach out to the team, the palliative care team, with your questions. As mentioned, we will be sending out slides and copies of the forms that were shared with you tonight. We also recorded this session, so we'll send the link for the recording along as well, in case you wanted to go back and take a listen to anything. But on behalf of the division, I just want to give a warm thanks to both Sukaina and to Salena for sharing your expertise, your knowledge, and your time with us this evening. And for the physicians and residents on the call, thank you as well for showing up tonight, for staying, for the great conversation and great questions. It was a pleasure to spend time with you all this evening. Bye for now.
Thank you.
Bye.